Welcome to our next presentation on our PCORI-funded symposium. I have the pleasure of introducing you to Jan Dougherty. Jan is a nurse leader, an innovator, and a dementia care expert. She currently brings all of her years of working in this area to now serve as a dementia care consultant, and she has recently founded Travel ALZ, a company that supports families living with dementia to be able to continue to travel safely if we're not in the middle of a pandemic. She was the former Family and Community Services Director at Banner Alzheimer's Institute in Phoenix, Arizona, where she really was responsible for setting a new standard of care that we're going to hear about a bit today for those living with dementia and their families through the development and implementation of innovative programs, including early stage programming, arts and dementia, and an array of caregiver education programs. She was named Gerontologist of the Year in 2003 by the Arizona Geriatric Society. She is a noted speaker, international and national and local, and is also a fellow in the Academy of Nursing. I had the pleasure of meeting with Jan. When we were starting our program, I emailed to a few different people, and Jan was the one who got back to me with the most welcoming email, and I loved what I had seen online that they were doing with their program. And she's been, I think, a mentor for me and a model in the work that we're doing. And she was actually here 2 years ago, next month, at our dementia-friendly San Antonio Town Hall, when we had so many people together that said, just as Cynthia talked about, we need to really move in our city at dealing with the stigma attached to Alzheimer's disease and that diagnosis. And she's continued to support our program. And I'm so pleased that she's here today, I think following up very nicely from Cynthia on living well with dementia. Thank you so much, Jan, for coming today virtually.
Yes. Thank you so much for having me, and what an honor to follow Cynthia. And I think hopefully it'll just be synergistic. I think we were very much aligned in thinking about what to bring. So I'm not a person living with dementia, and I've spent probably over 30 years of my profession working with people with dementia and care partners who have been my greatest teachers. So I guess I want to share and impart some of the things that I've learned that hopefully will encourage us all to move forward with this idea that it is possible to live well with dementia. So I'm going to talk about a new pathway and what that looks like, because currently we're still in a medical model in the US in terms of how we think about what it means to have a diagnosis of dementia and what it means to live with this chronic condition. And then I want to talk about some strategies that can enhance life for people living with the dementia, while also educating, supporting, and engaging care partners who we recognize are cornerstone, particularly as we know this is a progressive condition. And then I want to recognize what I call these I statements of, again, the voice of people like Cynthia, who are our teachers, that will help us really guarantee or help, I guess, promote this idea that we can help people live well. And these I statements come from the Alzheimer's Disease International report that was out just this year. And they're from a group of individuals living with early stage Alzheimer's disease and related dementia in a small area in Japan, where they come together to really recognize what it is that is important to them and the people who support them, meaning their care partners. So I'm going to quickly go through these first slides because I think Cynthia has really outlined for us that people living with this condition are demanding a better deal, and there's such a push for researchers and clinicians to promote early diagnosis. But if the diagnosis results in what a colleague of mine called diagnosing adios, meaning you have Alzheimer's disease, you have Lewy body dementia, whatever it is, oh, we'll see in 6 months. And oh, by the way, get your advance directives in order, which has been the standard of care. This is just not working. And really, why should I come forward if in fact you're not going to provide a better opportunity for me? And so we need to recognize that people living with dementia are demanding that we see this as a human rights issue, and that we can ensure that they can live the highest quality of life with dignity, without isolation, stigma, and discrimination. And I will tell you, you know, as you look at this as a worldwide issue, a global issue, we see that in fact, in many ways, that our care model is failing individuals to achieve the highest degree of wellness. And so we need this new pathway of support and care that looks beyond activities of daily life, or looks beyond the mini mental state exam that people with dementia will get when they go in to see their physician, if you will, to do follow-up. And that's very much a loss-based model. Again, looking, as Cynthia said, not assessing strengths, but looking at what people no longer can do. And so this idea that we need to create community-based programs that allow people to be part of their community, that allows them to, again, this idea of living well. Cynthia talked about the importance of offering people rehabilitation, you know, giving them opportunities to learn strategies. I mean, we would be stunned if we were to hear of someone who had a stroke and was never offered the opportunity for physical therapy, occupational therapy, speech therapy, whatever that might be. And yet people living with dementia or getting a new diagnosis aren't offered those same strategies, particularly around occupational therapy, that can put into place strategies that help this person live independently and well for a much longer period of time than what we currently see. Again, we need to think about support groups and support for the person living with this condition, to recognize that there is grief and loss, much like Cynthia just discussed, is the anger and the frustration of why me, and striking me down. And, you know, and I don't care if you're 49 or 69 or 89, it's still a loss. So having this peer-to-peer contact becomes a critical element for people also to live well, because again, I know a lot about Alzheimer's disease and related dementia, but humbly, I don't live with it. So I think to be in communion, if you will, with others in a like situation can bring tremendous support. Again, we need support for people to work. So I was struck by Cynthia's comment that her neurologist told her at the time of diagnosis, you can no longer pastor a congregation. It kind of makes me gasp to think about, well, no, maybe not in the same way that she once had, but in a way that draws upon her strengths and her abilities to still provide meaningful work and meaningful contribution to a community that she cares about, being her faith community. Likewise, following volunteer opportunities that are meaningful. And, you know, in the Phoenix area, we've tried to do some work in this area. And again, the stigma around what people think about dementia says that, oh, these individuals aren't allowed, or they must be with someone. Again, because we're looking at loss versus the innate abilities that still exist. And then we're talking about people who need inclusive and accessible communities. And that's really all about what the dementia-friendly community is about. And finally, people with living with dementia are saying, hey, we need an educated healthcare staff. And this is where I do get on my high horse after being in this field for many years. I started my nursing career actually in rehabilitation, for which I had a great deal of training. And then I moved into the critical care area. Again, lots of education on that so that I could be a competent practitioner. And yet we're not providing the kinds of education that our healthcare staff need at all levels in order to be dementia capable, whether that be in the long-term care settings, whether it be in our community settings, or whether, again, be in our hospital settings as well. So I think if I were to go in, if I had a heart attack today, I'd want to go to a center of excellence for heart care, but we don't see a lot of that as it relates to dementia care, and I find that really quite disappointing and an opportunity. So I want to share with you this new paradigm that I think is something that we need to adopt here in the United States. And this comes out of the United Kingdom, where they've now for many years had this WELL pathway for dementia care. Because in the US, we've been very focused on managing symptoms rather than focusing on what it means to live well. Now, I've known people with chronic conditions where their symptoms aren't well managed and yet they're living well. And I've seen people with chronic conditions where their symptoms are tightly managed and they're not living well. So I often ask my physician colleagues, what would you rather do? Have your symptoms tightly managed and not live well? Or to live well and maybe your symptoms aren't managed? I'm not saying we shouldn't manage symptoms, but if all our focus is on that, then we're going to miss the bigger opportunity of helping people really live fulfilling lives. And so this paradigm, as you can see, starts from preventing well to dying well. And I think we need to, and I'll make some comments about dying well because, hey, we're all going to die. And I think the sooner we come to grips with that and having conversations about what that looks like for me, and that's with or without a dementia diagnosis. I think it's an incredibly important one. We need to have those conversations. So when we talk about preventing well, that's the space before symptoms ever appear. How do we make sure we try to minimize the risk? Diagnosing well, I'm going to talk about the timely and accurate diagnosis and having a plan of care that really supports the person and the care partner. We're going to talk about supporting well, which is access to safe, high quality health and social care for both people with dementia and their care partners. And in the UK and around Europe, you'll see them often referred to as carers. Living well really speaks to how do we help people live normally? I mean, that's what we all want to feel is normal. We want to feel safe and we want to feel accepted. And then finally, as we all come to life's end, that we can die with dignity in a place of our choosing. And you'll see these I statements that are in each one of these areas, but I will expand upon them in some of the areas that I have taken from the Japanese. So before we begin to break that down, the reality is that, you know, we're imperfect people and we live in an imperfect world. And so we will never find nirvana in the best of all that we're trying to do. And so I love the work of Dr. Pauline Boss, who is a family therapist who wrote a wonderful book called Loving Someone Who Has Dementia. And she really bases her work on grief and loss, that this is that dementia creates ambiguity, you know, uncertainty, and with that uncertainty, it creates a lot of loss and a lot of sense of fear and anxiety. And so she says that when you love someone with dementia, the goal is not perfection. The new standard for your relationship is simply for it to be good enough. She goes on and says, life with dementia can be less than ideal and still be pretty good. The perceptual shift is under your control. And I think that is so important as I continue to work with colleagues in the field, is how do we find the good enough? As I work with family caregivers, how do we think about what is good enough? Because if we hold ourselves to a standard that simply can't be met, we're going to fall short, and we're going to focus on, again, what we can't do versus what we can do. So again, I think whether you're a person living with dementia, focusing on what's going to be good enough, what is it you can still do, how do you control your thoughts and emotion? As a care partner, what's going to be good enough for how you provide support and love and relationship to the person you're caring for? And for those who work as professionals like I do, how can we ensure that what we're doing is good enough? So with that, let's look at this wellness paradigm. And the preventing well is really this idea that we can minimize the risk of dementia. And I think this is a really exciting area to see that at one point scientists kind of poo-pooed, oh, there's nothing you can do to decrease your risk of developing Alzheimer's disease or related dementia, but in fact, we have growing evidence about lifestyle factors that in fact are delaying the onset. So this WW finger stands for Worldwide Fingers, and it's really an outgrowth of a study done in Finland called the Pointer Study, where they had two groups. So this is like coming back to what PCORI does, looking at a group of people who were entered into an intervention where they exercised, they did cognitive engagement, and they learned about the condition and had an eating program, if you will, that was really about heart healthy food, if you will. The comparative group were just given information. It was up for them to figure out what they wanted to do. Well, of course, fast forward, the people in the treatment group who were engaged with physical exercise and eating well and cognitive engagement showed a tremendous decrease in the onset of dementia. So subsequently, this program now is happening throughout the world, and in the US is called the Fingers Study, and I've given a link here if you want to read more. We also learned in the last several years that another study was being done where they were looking at really aggressive management of particularly vascular risk factors around the treatment of high blood pressure or hypertension. And it turns out that when primary care doctors started treating blood pressures far more aggressively and getting them back more into the 120/80 range versus saying, well, you know, you're 74, and it's okay that your systolic, your upper number is running around 135. Well, they found out that in fact, when they had tight control of these risk factors, that there was a decreased incidence of vascular dementia, very much tied to Alzheimer's disease. And likewise, we're now looking at that relative to the metabolic risk factor as it relates to diabetes. And many of you probably have heard, we often call this type 3 dementia, because we know that this really can significantly increase the risk of onset of Alzheimer's disease. We've learned just in the past few years that hearing loss looks to be as another risk factor. And in fact, I have a brother who, you know, at age 60 has developed a pretty significant hearing loss. And what I see is his mood has changed, his willingness to participate in social groups, because it has become so overwhelming, even with the added, you know, assistance of hearing aids. So this becomes incredibly important as we think about, from a primary care prevention perspective, are we assessing for that? Are we saying, oh, you're just getting old and hearing loss is part of getting older? We've known for a long time that depression can be a precursor to the onset of Alzheimer's disease. And so I think identifying depression and managing it, which doesn't always include medication, but talk therapy, if you will, can be quite effective. And then finally, for a long time, studies continue to show how important a social network is. And so this is one of my biggest concerns for older adults at this point, and younger people as well, is that this enforced social isolation is really just bad for our cognitive health, and that's for all of us. So when we think about opportunities for preventing well, I think, yes, there is a variety of virtual programs for both physical and cognitive engagement. I know that I quit my gym because of the current situation, but my weight started creeping on, so I found some virtual programs that will suit me. And yet we need to think about those areas. I was just in northeast Arizona on the Navajo reservation, where much of that reservation is without having access to broadband and the kinds of things that bring programs into their homes. We need safe socialization, right? We need to find ways to get us back together. This isolation just is not good for all of us. And as we think about wellness checks, how important that is for us from our teen years into our middle-aged years, older years, this not only check for high blood pressure, which is the HTN hypertension, but diabetes, screening for hearing, looking at depression and asking about it, and yes, screening for memory. And it's really interesting. I'll talk a little bit more about this in the diagnosing well, but you know, by and large, we don't even have a standard for how we're asking primary care providers to assess memory. And so subsequently, it's just randomly or not done whatsoever. So when we see that there are these concerns, we need to ask this healthcare provider to follow up for these concerns. And certainly telehealth has been terrific. I just had a colleague, though, that I saw the other day who's been getting telehealth for some GI problems she has. Yet I saw her in person and I said, Sylvia, you are yellow. She was jaundiced. You need to have a practitioner lay hands on you. So again, how do we marry those two things together? Again, creating a dementia-friendly community, I think, is essential, and it's part of preventing well. We have to start talking about this. We have to recognize that this condition is a condition that occurs far greater in older age, and these are people, and they're not all living in nursing homes and drooling, but rather they are functional people, they have abilities, and they can make contributions. And finally, Cynthia spoke to clinical trials, but certainly this is the hot area. And this NDALS now is a registry through the Banner Alzheimer's Institute that provides connection for people throughout Northern America to get connected to a clinical trial in your area. But as you know, there are many other ways. Diagnosing well is another critical element of living well. And Cynthia, again, I think spoke to this in such a beautiful way, saying it needs to be timely and it needs to be accurate. And there does need to be care planning besides, I'll see you in 6 months. So we need to move beyond this myth of, well, it doesn't matter, you know, there's no treatment, why do you bother? And in fact, I can tell you, I work with lots of healthcare professionals kind of who feel this, well, you know, the Aricept doesn't really work, and, you know, why do I want to depress them? And as you heard Cynthia speak so powerfully, well, because I think I'm going nuts, right? Things just aren't right. So in my experience, a timely and accurate diagnosis means that I'm not going crazy. There's a name for this condition that has created more challenges for my daily life. Again, sometimes there's no insight by the affected person, and I want to really speak to families who are on this call, or perhaps even professionals who aren't aware that maybe up to 40% of people who are affected by a dementia condition may not have insight to what is happening to them. So don't tell them they're in denial, because they simply don't see it. Just like my friend didn't see that she was jaundiced. So it's not that she was in denial, rather she lives with herself and alone and didn't see the changes. And so that can happen with people who are having changes in memory and thinking. Sometimes the family or the person don't want to see it. And part of that, I will posit, is because of the stigma. They know they're going to be labeled. They know they're going to be sidelined. So why would I want to run to get a diagnosis if I live in a community where all of a sudden, if I am living with dementia, they all of a sudden treat me differently, or they don't include me? We also need to understand that informants, you know, family members, friends, whoever is part of that person's network, need to be part of the care team, particularly when the person doesn't have the same insight to the changes that are happening. And certainly the use of specialists, I would say, are critical, particularly with the atypical kinds of dementias that we see. And yet a recent report from the Alzheimer's Association said 50% of our primary care providers just are unprepared to meet the demands of dementia care, and yet we're going to need them to do that. And so it's critical that we think about, how do we loop these folks into diagnosing well? And then finally, this care plan, which to me is incredible. How do we sit down with the person at the time of diagnosis, disclose the diagnosis in a way that gives them the factual information they need, as well as families, and answer the questions that they need to know now, but then begin to discuss with them, what does it mean for you to live well? So I'll just tell you, I wrote this book on Travel Well with Dementia because in my role at Banner Alzheimer's Institute, we were doing a lot of diagnosis with people very early in their dementia condition. Again, all kinds of dementias that we saw. And as we would sit with the family, and it was largely the nurses and social workers, and say, what's important to you in the next year or two? Often that long dreamed about trip or that family reunion, or one client I worked with returned to Denmark to see her father. Those became critical elements to what it meant now to live well with this condition. So I think there are opportunities for diagnosing well means that as a person living with dementia and a care partner, it's important that you find a team that works for you. So in my experience, sometimes a nurse practitioner, and I love my medical colleagues, so this is not at all putting them down, but often they're trained to really focus on managing symptoms where the nurse practitioner looks more holistically. And so perhaps following up with a nurse practitioner is going to be better than following up with a physician if you're in a primary care practice. Thinking about who's going to be in your social network, who is it that you want to be on your side, who's going to be part of this. So who are these people, whether they're family members or their friends? And then I'm so glad that Cynthia really spoke to the spiritual, which can be religious and it can be not religious, again, for people. We're mind, body, and spirit. And I will tell you, this is a spirit condition as well, and the spirit stays strong. So how do we find those people on our team that will support our spirit and our spiritual journey to ensure that we are nourished? We need ongoing care, and we need to have these discussions that happen with the team about focus on living versus managing. And again, I would advocate as a person living with dementia care partner, how do you go on living? Because this is a chronic condition that can last 10, 12 years. And it's so important that, yes, we want to manage, but we don't want to lose the opportunity to live in the meantime. And Cynthia certainly given us the fuel to say, hey, let's build on abilities, but let's support disabilities. So here are some of the I statements that come from our colleagues in Japan around diagnosing well, where they say, I received an early diagnosis and I have a reasonable degree of control over the treatment I receive and my life. I have a wide range of options for essential and or necessary supports to suit my needs, and I have a general practitioner, or could be a specialist, who listens actively to me and thinks together about my concerns. So I think these are incredibly powerful statements that really support the idea that we do a timely and accurate diagnosis and ongoing care. Now, this supporting well in this paradigm looks at high quality health and social care for both the person living with dementia and the care partner. Once again, Cynthia really addresses beautifully, saying we really need to make sure that we're referring to support services. And, you know, even in centers where they have everything under one shingle, it might not work for them. So we shouldn't assume that we're the only provider. I love the Alzheimer's Association, especially their early stage programs are incredibly helpful to so many people living with the dementia, especially peer-to-peer, but also care partners. And through these programs, I have seen these lasting friendships be created. Again, part of when you live with a chronic condition, you have to kind of create your own community. We want to be with people who share a like journey. Again, memory cafes have been incredibly powerful. And, you know, I often say, if you don't have one, start your own. I'm working right now with a group of residential communities, and I'm saying to them, start your own community. Look, you are serving 500 people under this roof, and many of them are living with dementia, and their partners are living in independent where their loved one with dementia might be in memory care. Please find a way to bring them together and support kind of this peer-to-peer, whether it be a discussion group or whether it be an engagement group. And I like this idea of engagement, of how do we help find persons living with dementia and their partners to do fun things together. This hyperlink is from Massachusetts, where they have put together just an amazing toolkit that will help you start your memory cafe if that's something that you might want to do. And you could do this within a faith community as well. I live in a retirement area of the US in Arizona, and many of our faith communities largely are made up of older adults. Well, a good portion of them are probably living with dementia or experiencing in some way. So start a memory cafe through your church. Nothing will prohibit that. OT, I am such a fan of occupational therapy. I think especially right out of the gate, Cynthia gave us a clue into her life, what she's doing to help her maintain her day-to-day and help provide reminders. But OTs are brilliant with strategies and solutions to help simplify a lot of the demands that press on areas of the brain that are more challenged now by this condition. Grief counseling, as I mentioned, both for the person living with dementia and the care partner. And then here's one other opportunity. There's a group, and I'll be curious to hear from Cynthia if she's ever connected with Dementia Mentors, but this is a group of people who are living with dementia. The group is run out of New Jersey, but they too have online meetings. So they have peer-to-peer connection. So that would be another opportunity. So our opportunities are for supporting well. First of all, we should all know about what are resources in our area, be part of building a dementia-friendly community where there are multiple touch points that people throughout our greater community know about. How do we provide referrals to places that people can get connected, can get educated, can be supported. Grow the number of dementia friends. This is just a basic awareness program that teaches people what dementia looks like and how they can communicate and how they can offer assistance when they see it in their community. I know here in Arizona now, I think we're up to over 10,000 dementia friends. And that is because we created what we call these Dementia Friends Champions, a person who goes through a 2-hour training and says, hey, I'm willing to bring this to my neighborhood, to my block watch, to my book club, wherever that might be, to my scouting group. I think it's incredibly important that as communities and organizations, we work together. For too long, we've been siloed. We work against each other rather than working together. There is so much need that exists within our communities. The more that we can synergize our efforts, the greater we're going to be at reaching the people that we care about. So share what works. Don't. It's like don't hide it under a bushel. No, I'm going to let it shine. So shine your work and let people know how they can get connected. So some supporting statements in this area. I can express my true feelings to my family and friends, and they understand and support me. My care partner's role is respected and supported. Care partners in my area receive proper aid from their local community that enhance their role. I have friends with whom I can be myself and I can enjoy my time with them and talk about my concerns openly. Oh man, this is just so necessary in terms of supporting both the person and the care partner to live well. So here we now move on to living well, and this idea that people can live normally and can be in a safe and accepted community. Gee, that we expect that people like Cynthia can still drive in a way that's safe and it's accepted versus saying, oh, you're driving? What do you mean you're swimming a 1.5 miles in a lake? You could drown. You have dementia, right? This is often the paternalistic place that we come from. So we really need to challenge ourselves and understand that these dementia-friendly communities that we're building are inclusive, and people truly are included and they're welcomed, and we look for ways to provide meaningfulness to them and that we know them at a fundamental level. And this is where I'll come back to the spirit of knowing what brings joy, even in the progression of a disease when perhaps they can no longer express themselves in the same way. We know them and we know what brings meaning. It includes accessible design. I've become really excited about looking at the design of universal spaces that we walk into, and how do we ensure that there's good signage and directionality, and that people know how to find toilets, because that's often what we're looking for. And how do we ensure that the lighting is right and the flooring doesn't create confusion for the person who are having these eye-brain changes, that it doesn't connect in a meaningful way. And now I'm going to come to really just saying that we need to designate training for all medical and non-medical staff. I have come to a place in my career, you know, I'm Cheryl, I'm 63 years old. I've been a nurse now for 42 years and 30 years focused solely on dementia. It is essential that we equip our medical and non-medical teams to understand what dementia looks like, because we have very negative ways of looking at the behavioral expressions that often will appear in people who are trying to communicate distress when their brain is not working in a way that supports them. Because as soon as we see them, we're very quick to give a medication to try to snuff out that behavior. So we have to work towards avoidance of psychotropic medications. So yes, we have to learn how to manage symptoms, but we first of all need to fundamentally understand what dementia looks like and what it means. So our opportunities for living well, I think we need to create and execute meaningful programs. And you know, I joke about bingo, but I do go into communities where bingo is a mainstay. And so I don't want to take away from bingo. But again, it's finding those things that really bring joy and bring a sense of self and worth. So for example, I loved hearing Cynthia talk about 500-piece puzzles, because I will tell you, many of my colleagues will say, well, they can't do a 500-piece puzzle. We'll give them a 25-piece puzzle, and oh yeah, it looks like it was created for a child. So we need to think about how do we engage people. I love the mask making, music and arts work. We've done such a great job in this area. And so now we're translating a lot of that into virtual programs. And I think virtual is going to be here to stay. And I think that's okay, because there's going to be a subset of people who can't go out or choose not to go out. So we're going to need to invest in technology and think about this next group of people who will develop Alzheimer's disease and related dementia. So I love that Cynthia is using her phone. So frequently I've been listening into a number of webinars about technology, and we know that the earlier people use technology, the longer they will employ it in their living with dementia, and these can be incredibly supportive. So we now have a generation that will be quite savvy coming into a new condition. Once again, we need to partner, we need to share, we need to have ongoing discussions with the person and the partner about ongoing care. So some I statements include, I can engage in hobbies and activities that I've been involved with for years. I've been committed to the development of my community, as is Cynthia, by being engaged in my favorite work and community service. I have opportunities to spontaneously learn about dementia and live life with dementia. I have opportunities to share my experience of living with dementia and make policy recommendations. They should be setting the policy, not those of us who don't know what it's like. I am not discriminated against or treated differently, even though I'm living with dementia. So in one community I was in recently, I will tell you that in the independent living, they don't want those people from the memory care unit coming into their dining room. Really? That is outright discrimination, and they're not looking at the person. And then finally, this idea of dying well. You know, we all want death with dignity, and we want to do it in a place of our choosing, instead of people who are living with dementia. So people who are in residential settings, they should be allowed to stay in that place and not move to another unit, so that they're cared by staff who know and love them. And we need to employ comfort approaches that are multisensory and that are supportive, and looking a lot at eating, because food is one of the last things to be enjoyed. We need to move from reacting to needs to anticipating needs and truly knowing the person, because our goal is to keep people out of the hospital. So our opportunities for dying well, again, it's early and continued education, support, engagement of the person and the family. And I will tell you, I had the privilege of starting one of the first end-of-life dementia hospice programs. And I would never go into a discussion about treatment without the person with dementia being there and being part. And while people might have thought they weren't engaged, oh yes, I can tell you how many times they rose to the occasion and were able to communicate in a very clear way what their wishes were. So hospice care is incredibly needed. We want to allow this person to die where they've lived. We want to use music, chocolate, and prayer. I will tell you, in my experience, those are three of the most powerful things that connect this person. Again, mind, body, spirit. The mind might have been racked by this illness, but the spirit is alive and well, and we need to minister to it. And finally, aggressive management of pain, which is due to lack of movement. And that doesn't mean morphine, by the way. Actually, routine Tylenol works quite well. So I'm going to come back to my original comments from Dr. Boss, who says that life with dementia can be less than perfect, but it still can be pretty good. Because indeed, I believe the perceptual shift is under each one of our control, whether you're a person living with a condition, whether you're a care partner, or whether you're a professional. We have to shift our perceptions about what it means. And yes, I understand that this is a progressive condition, but when we focus on preventing well, diagnosing well, supporting well, living well, and dying well, we can provide hope, we can provide help, and we can provide comfort to a life that is well lived. So with that, I'm going to stop. I apologize if I've gone over my time, but I certainly welcome thoughts and questions, and would love to hear from you.
Jan, thank you so much for such a comprehensive presentation. And I love those I statements. I think they shift our focus they reframe how we think about dementia. And so I think what I'm going to do is we have just one I think we have time just for one question, because I do want to make sure we give sufficient time to the panel. But I want to just have this question here. Jan, from your perspective, what is a good way to dialogue about dying well, not only for the person with dementia, but also for the family? And I think you talked about this a little bit, but if you can just maybe take a couple more minutes to talk about those conversations.
Well, first of all, I wouldn't wait until advanced dementia. So oftentimes it's not talked about. Now, I don't think at the time of diagnosis we should say, oh yes, and this is a terminal condition. So I get a little tired of us batting around. It's the sixth leading cause of death, because that is a defeatist attitude. But as part of living with a chronic condition, the conversation should come up about, again, what's important to you, knowing that this could be the cause of death. And let's talk about that. So let's talk about the decisions that are important to you. You know, much like I talk about even early on, at what point can you no longer live alone? And what will be the best supportive place for you to live? You know, this to me is a continuum of discussions that we don't have once, but we have repeatedly. So for example, often in moderate stage, so now a person is needing much more assistance for day-to-day, families will come in and say, well, her doctor wants to do a mammogram, or they want to do colonoscopy. And this is where we have to say, well, if they were to find cancer, and this is where they are, would you want to treat it, knowing that it can cause so much more disability and distress now to a person who perhaps can't even understand what's happening, right? So we begin to have those discussions very openly and honestly. And, you know, quite honestly, we need to be sure that we are representing the desires of the person. So I will tell you, a colleague of mine, very esteemed in this field, his father, who was a physician, developed dementia right in the midst and fell and fractured at home. So he ended up in the hospital and then in a skilled nursing facility. And as you can imagine, became more confused, right, due to the pain and the medications and the anesthesia. And so, you know, he text messaged me, what should I do? And, you know, the first question was, you know, we need to talk. So the first question is, what would your dad want? You know, because this was a turning point. Do we think about making a referral to hospice care? Because quite honestly, his prognosis could be very poor from what we know. Or do we want to pull out the stops and see what that's going to mean? And he very clearly said to me, my dad loved life. He would say, don't give up on me now, pull out the stops. Hey, so we pulled out the stops. But I've worked with other families in a like situation who would say, you know what, you're right. They would never want to live this way. They were very clear with their expressions. So again, it's a discussion that we should all be having in our lives. I have them routinely. I had children late in life, and I've been very clear to them about what is important to me in my life and in my death. And I'm not being morose. Rather, I want to prepare them that they can stand tall and not second guess the decisions they've made. And I will tell you, the reason I went from my hospice work to Banner to start early stage programs, because I was working with families who were beating themselves up, saying I would have, I should have, I could have. And the reality is, when we have discussions early and we have them repeatedly and we include the voice of the person as it's possible to do that, then we can stand tall at the end of this journey and say, I did my best. And that's what I wish for every care partner. And I think every person living with dementia wants to say to their family, thank you for loving me, for caring for me, and respecting me right to the end.
Thank you so much, Jan, and thank you for such a meaningful presentation.